Hi, Omkar.
Hi Pudyan, how are you?
Yeah, fine. Hi, Nilay. Hi, Bhavna.
Hi Pudyan. Hi Omkar.
Hi Nile sir.
Hi,
Hi Bhavna.
बढ़िया
Hi,
बढ़िया.
hi everyone.
So,
Hi
कैसे
Bhavna.
सब जाने का प्लानिंग?
huh?
All set? All set for Goa trip?
Yeah. All set. I just need a company. That's all. Everything else is set.
Mentally, तो we are prepared 2 years back only.
Uh,
You will get enough company. Don't worry.
Obviously.
कितने बजे तक चाहिए?
अब बताओ कितने बजे
कितने
तक?
बजे तक चाहिए वो पूछने का है. Till what time?
Casino so it's all right open ना?
yeah. Hi, good evening.
Hello Rajesh sir.
Hi, hi.
Good evening, sir.
Hi, sir. Good evening, sir.
Hi sir.
Hi, hi. Good evening. Okay, have you checked your PPT, Rankur?
Yes sir. Shall I share the screen and let's see?
Yeah, just can you check it before we start?
Is it visible sir?
Yes.
Okay.
Yeah, we'll wait for 5 more minutes.
Yes sir.
Hello, everyone.
Hi.
Hi, ma'am. Hi. Hello, sir. So we'll just wait for a few minutes, another 5 minutes, and then we will start Omkar.
Yes sir. Dr. Priya, how was the workshop this time?
Good, good. Richa was around this time, and
Yes, I know.
yes, yes, it was nice. I mean, interesting cases and
Lot of valuable opinions across the country.
yeah.
All seniors were there, no? This time.
I think few of them could not come because of some health issues, but there were a lot of seniors. Yeah.
Oh, okay, I see. Speaking of the famous person had joined. Hi, Richa.
हाय
We were talking about you only.
अरे बाप रे मेरा नाइट ड्यूटी इसलिए है क्या मस्त प्लान्स चल रहे हैं गोवा के सबके
All set to Goa. Pudivan is very excited.
Pudyavan is excited, so Pudyavan's excitement is inversely proportional to my excitement.
Why is that so? We have work-related issues.
Correct now, Pudyavan?
Yeah. I am trying to poach Vimal sir, and she is not allowing.
Hey, now I really cancel. You keep falsely blaming me.
अभी तक इशू सॉल्व नहीं हुआ लगता. हाँ, पुदियावन.
What?
The issue is not yet solved.
Arey, it's
The
solved.
issue? It's
It's
solved.
There is no issue only.
I am working. Dr. Vimal is going for a long drive.
Oh,
Okay, great.
Pudivan is smiling
So
behind.
NH is going to get great reports then.
Yeah, always.
This is optimism.
So, all of you have booked your tickets to Goa?
I did not say yet.
Not yet.
But one team is planning by road?
No, sir.
Kovai via Bangalore? Yes, sir. So I am planning to drive to Bangalore, pick up Vimal sir, and then drive to Goa from there, sir. Oh, great.
Richa is also joining.
Richa will join Goa Friday directly by flight. Not booked yet. I think we booked last
But
minute.
it will-
Should we start now? Sir, it's 8:05.
I have given Richa the option of work from car, so she can take that. Yeah. Okay. So we'll start the session. Good evening, all. Warm welcome to today's Journal Club. I welcome Dr. Ankarati. Today's topic is on multiparametric assessment of LV hypertrophy using LG and T1 mapping strain encoded CMR, and which is a very common clinical cases what we used to come across. And this article is from the which journal?
JCMR.
JCMR. Yes. So then we'll move to the journal presentation. I welcome once again Dr. Honkar. Please get start.
Thank you, sir. Are you able to see my screen?
Yes. Can go ahead.
So today's topic is multiparametric assessment of LV hypertrophy using late gadolinium enhancement, T1 mapping, and strain encoded cardiovascular magnetic resonance. So this particular article is published in 2021 in JCMR. So LV hypertrophy is defined as increase in LV muscle mass LV hypertrophy is usually the adaptive process which develop over time in response to wall stress or hemodynamic pressure or volumetric burden. So it may be increase in afterload or increase in preload. The increased mass of a muscle fiber or wall thickness serves initial as a compensatory mechanism, and which helps into maintaining the contractile forces and which counteracts the increased ventricular wall stress. However, if there is significant increase in workload of the LV, so the LV wall becomes stiff after a certain while, which is associated with increase in diastolic ventricular pressures, which subsequently transmitted back to the left atrium as well as to the pulmonary vasculature. So initial adaptive process of a LV hypertrophy chronically will increase the workload of the heart, and then it will become transformed into the pathologic LV hypertrophy, which increases the risk of heart failure, dysrhythmias, and sudden cardiac death. That's why we need to find the cause for LV hypertrophy and treat it to avoid all these complications. So between different causes, this is the pathophysiology of LV hypertrophy. So the first mechanism is the increase in afterload, and the other mechanism is increase in preload. So if the afterload is increased, then there will be proliferation of cardiac fibroblast, increase in number of myocytes. Also, there will be addition of sarcomeres in parallel to the contractile force. So overall, there will be thickening of LV myocardium, and it will represent as a concentric hypertrophy. On the other hand, if the preload is increased, it will lead to the activation of ECM proteinases, which eventually will lengthen the myocyte length and increase the elasticity and muscle fiber movement. In turn, the LV also will have some dilatation and increase in chamber size. So in this kind of scenario, chronically there will be eccentric LV hypertrophy. So common causes of LVH, as I told you, that there is increase in afterload. So the causes are essential hypertension, renal artery stenosis, aortic valvular stenosis, coarctation of the aorta, or the subaortic stenosis. Increase in preload, the causes are aortic regurgitation, mitral regurgitation. So basically valvular heart diseases, congenital heart diseases like ventricular septal defect, and obviously the dilated cardiomyopathy. So there is another form of LVH where the structure of the myocyte has been altered, like hypertrophic cardiomyopathy or the infiltrative cardiac processes like amyloid, Fabry's, and Danon disease. The other kind of hypertrophy is physiological one, which we find in the athletes, or we call it as an athlete heart. So in this, the echo is a very good modality to screen all this and to detect the LV hypertrophy. Echo is again very good modality to detect the valvular heart diseases, congenital heart diseases. So we are taken out the increase in preload part. It can be very well diagnosed by the echos. But again, echos will have limitation deciding whether it's the hypertrophy is due to the hypertension, or it's a hypertrophic cardiomyopathy, or whether it's an infiltrative process or athlete's hearts. So for that, the current study has concentrated on four different clinical entities. So one is the competitive athletes, the hypertensive heart diseases, hypertrophic cardiomyopathy, and cardiac amyloidosis. Also, they have included healthy subjects to have a control. So cardiac MR provides a comprehensive information in terms of LV hypertrophy. The cardiac, it gives the morphology and function, it gives the LV volumes, it gives the LV hypertrophy, the wall thickness, exact measurements. The T1 mapping also helps in differentiating the diagnosis. Late gadolinium enhancement has a major part by its different patterns in different diseases. And the strain imaging, we are going to assess the effect of strain imaging in identifying and differentiating LV hypertrophy. So aim of this study is to evaluate ability of a single heartbeat fast strain encoded, which is a SENC CMR derived myocardial strain, to discriminate between the different forms of LV hypertrophy. So methods, the study has been done during the period of September 2017 to February 19 in Marian Hospital, Hamburg, Germany, and German Heart Center, Berlin, Germany. So they have assessed total 1566 CMR scans. To all these scans, the inclusion criteria was applied, which include the evaluation of LV hypertrophy, which was previously diagnosed by echocardiography, the evaluation of underlying symptoms for heart failure, and evaluation of any known or suspected cardiomyopathy. So out of 1566 cardiac MRs, only 314 met the criteria. In addition to this, they have included 22 competitive athletes into the cohort and 33 healthy subjects into the cohort. So total number of subjects is 369. Certain definitions to proceed ahead. One is the LV hypertrophy. If the wall thickness is more than 12 mm in any LV segment, it is labeled as a LV hypertrophy. Hypertensive heart diseases, uh, there is presence of LV hypertrophy with known arterial hypertension, and in absence of any other cause is labeled as HHD. Hypertrophic cardiomyopathy, when the wall thickness is more than 15 mm or more than 13 mm in first degree relative of known HCM patient. These are labeled as HCM patients. The cardiac amyloidosis, they have done the Congo red staining or other available non-invasive diagnostic criteria to diagnose amyloid. Competitive athletes, the criteria was it has to be a marathon or triathlon runners or bikers or football players which are trained for at least 3 years or and at least 5 years in a week with intensive aerobic and anaerobic exercises. Okay, so they included the conventional CMR protocol. It is a standard CMR protocol as per the SCMR guidelines, which included the long axis cines in 2 chamber, 3 chamber, and 4 chamber, short axis stack of cines, which are valuable to quantify the LV volumes. So LV volumes, LVEF are calculated by standard measures and using the analysis on CVI42 workstation, which is by the circle. They have also calculated myocardial contraction fraction, MCF, which is calculated as a LV stroke volume divided by LV myocardial volume, where the LV myocardial volume is LV mass divided by 1.05. They have done the T1 mapping using the modified look locker inversion recovery, that is MOLLE sequence. They have included the PSIR late gadolinium enhancement images, which are acquired 10 minutes after the contrast. So in assessment of LG, first they have assessed whether the LG is present or absent. After that, they have divided the LGA patterns into three prominent group. One is the diffuse or patchy multiple LGs. Second is the focal intramyocardial or mid-myocardial LGs. And third is the focal epicardial LGs. They have assigned a LG score to all the patients. So LG score is defined as number of segments with atypical LG. So whatever the number of segments of atypical LG in that particular patient, which is divided by total number of segments, which is 17. So that becomes a LG score of that particular patient. And LG pattern, they have characterized as a most frequent pattern. So let's say if one patient has diffuse pattern as well as some focal intramyocardial pattern. So if the number of segments with the diffuse pattern are more, that subject is labeled as a diffuse or patchy enhancement or patchy atypical LG. So a little bit about single heartbeat sync. So it's a, as the name suggests, it's a single heartbeat scan. Acquisition time is less than 1 second. Longitudinal strain is extracted from the short axis views. So short axis views are taken at the basal, mid, and the apical. So three cine images has been taken using this sequence, and the longitudinal strain has been derived from that. And for the circumferential strain from the long axis view, which is 2 chamber, 3 chamber, and 4 chamber. So the fast sync protocol imported into the dedicated software, which is a MyoStrain software available at their site. And the information extracted from that, which is global longitudinal strain, which is derived from short axis images and which is based on 16 segment module. The another information they got about the global circumferential strain or GCS derived from the long axis views and which is a 21 segment model. The normal GLS or GCS is defined when it is equal or less than minus 17 percentage. So more the negative the number is, that is a normal strain basically. So if it's a minus 22, that's a normal. If it's a minus 15, then that's an abnormal strain. So of all this information, they have calculated the percentage of normal myocardium, which is number of segments with so number of segments with circumferential or longitudinal strain less than or equal to minus 17 degrees. So number of normal segment strains divided by 37. So 37 is the summation of the 16 segments of GLS and 21 segments of GCS. So that's why it's 16. So percentage of normal myocardium is basically number of normal myocardial segments divided by 37. Let's see. Going on to results, the total number of patients is 369. Out of those, hypertensive heart disease have 228, 45 patients of hypertrophic cardiomyopathy, 41 patients of amyloid, and 22 competitive athletes, and they have taken 33 healthy subjects. So this is the demographic, clinical, and CMR data for the study cohort. In that, what we have seen that there is not much difference between the LV EDV and LV ESV. Ejection fraction per se, that ejection fraction is maintained in athletes and normal subjects, and it is decreased only in amyloid cases. Interventricular septum, if we concentrate on the thickness, you can see that the thickness is more in amyloid and the hypertrophic cardiomyopathy. Otherwise, the thickness is normal in healthy subjects. It's mildly increased in athletes. Again, the LG presence of LG, that there are no LG present in the normal subjects. There are some only focal intramyocardial or epicardial LG is present in the athletes. No diffuse LG in the athletes. The HHD has again more number of LG than athletes, and it has been increased in HCM and definitely in amyloid. So amyloid, all the patients showed diffuse LGE pattern. On the other hand, the GLS and GCS are normal in athlete and the healthy subjects. It is mildly compromised in the HCM. Again, it is almost normal in the HHD, near normal, and it is very much compromised in the amyloid. Okay. So on the basis of the data, there was very poor correlation observed between the LV longitudinal circumferential strain with the ejection fraction, and also with the ejection fraction. However, there is a moderate correlation between the percentage normal myocardium and the LV mass. Also, there is a moderate correlation between the percentage myocardium and the T1 values, also the atypical LG score. So this is the diagram which is showing the fast sang sequence, which is analyzed and colored map over here for us. So the blue is the normal color and the yellow is the abnormal one or the increased trend. So first column is the normal subjects, then the athletes, then hypertensive heart, hypertrophic cardiomyopathy, and the amyloid. So percentage myocardium is normal in the normal subjects and the athlete's heart. Again, it is compromised a bit in hypertensive heart. It is compromised much more in the hypertrophic and cardiac amyloidosis. The LV ejection fraction is normal in normal subjects, athlete heart, and the hypertensive heart. It is maintained in hypertrophic cardiomyopathy, and it is very much decreased in the amyloid. T1 mapping, on the other hand, it is normal in first two categories. In the hypertensive heart also it is normal. In hypertrophic cardiomyopathy is near normal, and in amyloid it's increased. So LG, as I told you, okay, so LG is, there is absence of LG in normal subjects, and the score increases in the amyloid. Amyloid shows diffuse LG. Again, this is the graph showing the similar thing, that this is the percentage of the normal myocardium, which is decreased in cardiac amyloid, and the hypertrophic cardiomyopathy, whereas it is normal in the athlete heart and normal subjects. However, the LVEF, the central orange line, showed no significant difference, and it is decreased mildly into the amyloid. LV mass index obviously increased in amyloid and HCM compared to other categories. So this is the comparison of the LVEF, LV mass index in different categories. So patients with SCM and cardiac amyloid exhibit highest mass index. So this is again a detailed graph of that. Highest, no change in the LVEF, only the amyloid shows decreased LVEF. LV mass index is highest in amyloid and to some extent in HCM. The T1 values are highest in amyloid. Atypical LG scores are again very much significantly higher in amyloid. The strain has been increased in amyloid and HCM cases more than the rest of the groups. Similarly, percentage of myocardium, normal myocardium is decreased in amyloid and HCM more compared to the other groups. So they have again studied the our most clinical dilemma comes in a mild to moderate LV hypertrophy, where the LV wall thickness is between 11 to 15 mm. If it is more than 15 mm, then it is obviously goes in favor of hypertrophic cardiomyopathy. And if it is less than 11 mm, then it's a normal heart. So they have addressed this issue. They are trying to address this issue, and they have compared the subjects with the septal wall thickness 11 to 15 mm. So in that, the athletes have 8 number of athletes have mild to moderate LVH. The 111 of hypertensive heart disease have moderate LVH. Hypertrophic cardiomyopathy number is 14 and 13 cases of amyloid. So again, if we see the LV ejection fraction, there is not much difference between the groups. And the obviously now here the healthy subjects are gone out of the picture because we are talking about LV hypertrophy now. So LV mass index, again, it is increased in the amyloid. The MCF, which is the myocardial contraction fraction, which is decreased in amyloid and HCM per se. The T1 values are very much increased in amyloid. A typical LG score is increased in amyloid, and percentage normal myocardium is very much decreased in amyloid and HCM. So percentage of normal myocardium differentiated almost all groups over here with the mild to moderate LVH, except for SCM and amyloid. Okay, so this is the accuracy graph where the sensitivity and specificity are plotted over here, and they have compared the different clinical entities with each other. So first is the athlete versus SCM. So if we compare the athlete versus SCM, the percentage of percentage of normal myocardium is it has a high accuracy in differentiating between these two. The accuracy is little bit decreased in athletes versus hypertensive heart, but still the percentage of normal myocardium and the LGE shows good accuracy in the differentiating athlete versus hypertensive heart. In hypertensive heart and the SCM, the atypical LGA pattern is more accurate than the percentage normal myocardium. So that's an interesting finding. And in SCM versus amyloid, the both the percentage of normal myocardium, atypical LG have decreased their accuracy compared to the other groups. But overall, the percentage of normal myocardium and LGA score showed higher accuracies than T1 and LV mass index. So to differentiate between the hypertrophic cardiomyopathy and cardiac amyloid, they have assessed one more parameter, which is base to apex segmental strain gradient. That we know that the apical sparing happens in cardiac amyloid, which we call it as a cherry on top appearance on the strain images. So they have found that it was significantly higher. The base to apex segmental strain gradient is significantly higher in patients of amyloid versus HCM, and it helps to differentiate between these two clinical entities, especially in the mild to moderate LV hypertrophy. So these are again the summary or accuracy of the different clinical entities together. So as we see over here, the athlete versus SCM and athlete versus HHD, the percentage normal myocardium has good accuracy. Also, the atypical LG has good accuracy. In the mild to moderate hypertrophy, this accuracy even increases. The sensitivity and specificity even increases in athletes versus SCM and athletes versus hypertensive heart. And the rest of the hypertrophic HCM and amyloid, the percentage of normal myocardium and atypical LGE both have lower accuracies in that. And in mild to moderate, they have also increased a bit over here. The percent, but if you combine the percentage normal myocardium and the LGE together, it showed more accuracy in differentiating HCM and amyloid. Okay, so when we put all these factors together, whether it's a percentage normal myocardium, LVF, LG, T1 mapping, myocardial contraction fraction, and the LGE pattern. So if we combine together, it has been seen that it can definitely differentiate between the all these clinical entities. So it is called as the clustered based multivariable approach. So just a result summary, they have analyzed 300 patients, more than 300 patients, and they found that the percentage normal myocardium can reproducibly assess myocardial strain, but only modestly related to LVF, LV mass index, T1 and LG. Percentage normal myocardium, LV mass index, septal wall thickness, T1 and LG all differ to certain degree between different clinical entities. In patients with mild to moderate form of LVH, that is the wall thickness between 11 to 15 mm, percentage normal myocardium offers excellent accuracy between athlete versus SCM and athlete versus hypertensive heart disease. And combining a typical LG score with the percentage normal myocardium offers a high precision for differentiating between different clinical pathologies. We call it the clustered multivariable approach. And also good accuracies are provided between HCM and hypertensive heart disease and SCM and amyloid. A little more about the fast seq sequence. So it is also valuable tool in assessment of myocardial ischemia. So interestingly, there is no difference between the athlete and healthy heart individuals in respect to percentage myocardium. So percentage of normal myocardium is almost similar in athlete and healthy individuals. So this suggests that the healthy hypertrophy, which is associated with the sport activities, is a form of physical hypertrophy and probably in most cases does not adversely affect the function. So this is very physiological hypertrophy where the number of myocyte increases with not increase in extracellular volume. Okay, in patients with hypertensive heart disease, on the other hand, there is decrease in normal myocardium, which is noted in comparison with healthy individual and athletes. So that's a pathological LV hypertrophy. Patients with HCM exhibited worse myocardial strain than with the hypertensive heart disease, and lower values even found in amyloid. So even if we consider the fast sync, the none of the healthy individual or athlete have the 100% normal myocardium. So even these are healthy subjects, the percentage of myocardium is never 100 in their study population. So the possible explanation for this can be there are regional differences between the different aspects of the myocardium. For example, there is low longitudinal strain found in mid-anterior, mid-anteroseptal, and apical lateral segments. However, there is low circumferential strain found in many studies in basal anteroseptal segment and in apical cap. So some of the segments are, tend to have a lower longitudinal or circumferential strain, and these regional differences contribute to that, so that the percentage of normal myocardium even in healthy subjects is never 100%, but it ranges between 80 to 90%. So in summary, in athlete versus hypertrophic cardiomyopathy or athlete versus hypertensive heart, the percentage of normal myocardium shows promising clinical implications, and also it performed significantly better than T1 mapping. For differentiation between hypertrophic cardiomyopathy and hypertensive heart disease, and between HCM and amyloid with mild to moderate hypertrophy, combining LGE pattern with the percentage of normal myocardium offers a high accuracy rates. For differentiating between HCM and amyloid, base to apical segmental gradient has given further inputs in differentiating between these two clinical entities. So overall, the combination of atypical LG and the percentage of normal myocardium allowed us to differentiate between all these pathology using this approach. The limitations of this study, it is a very heterogeneous cohort. ECG data were not analyzed systematically. The age and gender matching for the normal strain and everything were not performed. Other infiltration cardiomyopathy were not included, like Fabry's disease or Danon disease or mitochondrial disorders. There were many overlapping phenotypes between the subjects. So like the patient of hypertrophic cardiomyopathy also has a systemic hypertension, or some of the patient were diagnosed as a HCM first, and then later on they have diagnosed as a amyloid. So there will be there were multiple overlapping between the phenotypes, and almost many of these patients have um, arterial hypertension in them. So they have recognized it as a possible confounder in the study. But at the time of scanning and everything, they have checked the blood pressures of those patients in HCM and amyloid, and they were normal. So cutoff of strain used over here, that is minus 17%. It cannot be used for other strain, not necessarily used for other strain methods, because this is specifically derived in this fast-senk sequence. So conclusion, the fast-senk derived myocardial strain is valuable tool for characterization of patients exhibiting LV hypertrophy, and can be used together with atypical LG to help establishing an etiological diagnosis in form of mild to moderate hypertrophy of unclear etiology. Thank you.
Yeah, thank you, Dr. Ankar. The nice presentation. Yeah, regarding this fast sync, the sequence anybody is having here in our group?
No, sir. In
Okay.
our group,
No, it's more like a research sequence, I think, not
Yeah, still not commercially available.
commercially available. Yes, yes.
Okay, okay.
But surprisingly, like in SENC sequence, they have mentioned that longitudinal strain is on the short axis and
yes.
circumferential strain is on long axis, which is
Yeah, why? I also want to ask that. Yeah.
yes, because in feature track means longitudinal strain. I think visually we imagine the long axis view
Long
and
axis. Hmm. So
but
I also
SENC is
had that query, but I went through the articles, but they have mentioned specifically in there. So I want to
yeah.
put it out there that it is I don't know,
But
maybe the sequence differs in, it functions in different way that we don't know.
but SENC is supposed to be very highly accurate for
Highly accurate,
strain, very
definitely.
high.
In the different feature tracking and everything, the sync is more accurate.
Yeah, good.
Yeah, just some observations. I think it was a very interesting what you call sequence. But this is a very common clinical problem. It's a very common day-to-day clinical problem, which we struggle sometimes to differentiate these four pathologies which they have talked about: the normal, the athlete's heart, the hypertension, HCM, and amyloid. And sometimes it can be very tricky. So I think this is a step in the right direction. Although, as you've seen in the article, there is no one particular feature which can accurately tell you what is what. And I think this confounding thing is going to carry on for some time. So I think it is very important, as people who view these diseases, that we look at everything that is possible: the patient, the ECG, the echo report, the GLS report, the MRI, even if you don't have any fancy tool, just the wall motion, the tagging, if you have it, the T1 and the scarring, all when you put it together, differentiate these diseases. And the biggest issue is obviously athlete's heart, wherein someone actually comes to you and says, "Can I go for competitive sports? Can I, be treated as normal?" Which is very tough. Sometimes it's very difficult, based on the available parameters on MRI, to say that. So I think this is the step in the right direction, and we must look at all aspects of the puzzle, put it together, reach out to colleagues, clinical echo colleagues, and then make that call. It will continue to, I think, give us some more trouble for a couple of years more. Thank you.
And again, in the athletes' heart, the accurate or the correct diagnosis is when we have to detrain them for 5-6 months or some time period, and then we need to check the LV hypertrophy has regressed or not. So that is the most accurate thing. But practically speaking, the athletes, they don't want to give up their training and everything what they have worked for. That is the most clinical situation we found in day-to-day life.
Yeah,
Any mention about left atrial strain in the article? I mean, have they done in those hypertensive
No,
patients or?
not in this article per se.
Does anyone know who is offering this as a WIP? Which company?
So, Senk is still not commercially available, but I think a lot of companies are in process of making this an AI-based algorithm for this, using everything, LG and T1 mapping and LV hypertrophy indices.
I want to ask one simple question, sir. So, what is the cutoff you choose to call it as a LV hypertrophy of the wall thickness? Whether it's a
I
12
use
mm, 13 mm, or 11 mm, is there any cutoff you decide that after that I will call this as a LV hypertrophy?
I think 12 millimeter and 12 to 15 will be borderline. Above 15,
Mm-hmm.
definitely hypertrophy. But any segment, means, even one segment more than
Correct.
15 millimeters should be considered abnormal. Yeah.
Right. So in different articles, they have given different cutoffs for that. So the best way what I think is to calculate the LV mass and to have a normalized LV mass for your population, and then you call it as a LV hypertrophy rather than based on wall thickness. But sadly, we don't have the normalized volumes or the masses in Indian population.
We should definitely do that. We do not have any MR indices normalized values for our Indian population. So we don't know what is normal myocardial mass.
That's what.
yeah, at least maybe we should have some unpublished data, at least among as a association. Maybe we can think about it. These are all the simpler things where we can use it as at least some internal check, some kind of guide. Even though if you want to publish only, then there are a lot of procedures taking concern, so many problems. But maybe yeah, if we can now pool the data of different population, then maybe in future we will have some normative data, at least now which can be used unofficially, at least among us. So that may be
That
future
is a
work.
very good idea. That is really important.
And what I found is that in Indian populations, LV mass is very much less compared to the Western population. So Western population, they have given the cutoff of 90 milligrams per meter square and all. But the Indian, even in the healthy, working adults and everything, it does not cross 60 in most of
Yeah,
the population.
55, 60 is on an average, I
Correct.
usually. Yeah.
I think as a part of ISA, we can start that, collecting normal values from normal patient and just use it for our practice.
Yeah, maybe you have to look at the standardizing these things. Now, how do we do the post processing and all those things? So, yeah, if we can standardize that, then I think we can able to start collecting the data. Let's see how we can go about it. So, any other points for discussion?
Sir, I just have one question. Omkar, very good presentation. Bhavna here.
Thank you.
Yes, Bhavna, yeah.
Yeah.
Go ahead.
Yeah. So you just one question I had regarding this myocardial contractility fraction. Is it something that most of us are using? Because I have never come across. It's the first time I came across. So I just wanted to know regarding that. And the second question was regarding the strain analysis. Is this whatever you mentioned? So I got to know that it's different from the routine strain analysis that is being used. But does the feature tracking strain analysis have any role in differentiating, or are we using it to differentiate different types of hypertrophic cardiomyopathy in clinical practice?
So currently we are using feature tracking method for the strain, which is commercially available, and most of us use that. So according to the papers, it also differentiates between the amyloid and the hypertrophic cardiomyopathy and all these clinical entities. But the fast sync is much more accurate in those terms, according to the papers. But I don't have a software of strain, so I'm not using it currently. But I think it's a very valuable tool in differentiating these kind of clinical entities.
And this myocardial contractility fraction that you mentioned, is it something that is just in the paper, or is anybody using it in the reports for LVH?
No. Frankly speaking, I have come across for the first time during reading the paper only. So mostly we'll start using now onwards, and let's see that if it impacts or if it changes the decision, or it goes easy with the decision making.
No, I think
Oh.
now the trend is maybe after some time the hematocrit will be, like the synthetic ECV and this MCF. That would be the level, especially whenever you want to make make a decision making algorithm, then this would be definitely counted, because there is lot of variability which could be involved with the patient specific parameters that will not be there, like. So even with ECV calculation, probably using the muscle mass and specific gravity and the MCF. If we are not using now, I'm sure we will start using it in some time.
No, definitely. The ECV is a very good game changer in that sense. In this article also, they have mentioned that we haven't calculated ECV and we haven't assessed that thing. So that may be the next step forward. And secondly, what I found that in the athlete's heart, it's a purely increase in number of myocytes where the ECV does not increase. But in hypertensive heart or hypertrophic cardiomyopathy, ECV increases. So again, the ECV has a very good factor over there to discriminate between these entities.
Yeah, I think we have a good discussion. I thanks Ankor once again, and we'll meet next month. Thank you all. Good night.
Thank you.
Good
Bye.
night.
Good night.
Thank you. Good night.
Thank you. Good night.
Good night. Good night.
Good night.